Thank the organizing committee, of course, for inviting me to give this strange talk. Actually, SBD stands for sleep disorder breathing, and theRWD stands for real world data. So, after my conflict of interest declaration, I would like also to thank the organizing committee because the data regarding the title are very limited, so my job will be not so difficult. Despite the fact that obstructive sleep apnea syndrome and COPD are very common diseases, actually the overlap syndrome occurs in approximately 1% of adults in the general population. We don't have enough data to support actually the PaP treatment, positive airway pressure treatment. And of course, we don't have enough data, real world data. We know that COPD is very heterogeneous. We have already heard that in the previous talks, but of course we have some factors promoting the presence of obstructive sleep apnea in COPD patients and other factors that are negative. For example, if you suffer from emphysema and you are hyperinflated COPD patients, it is less likely to suffer from obstructive sleep apnea. Of course, if you have rostral fluid shift, if you are obese, it is likely to suffer from obstructive sleep apnea. So we would like to highlight also that not only COPD is heterogeneous, PaP treatment is also not uniform. Actually, in the majority of the patients, CPAP in the forms of standard fixed positive airway pressure treatment or APAP treatment is appropriate. But in several COPD patients with obstructive sleep apnea, will use another mode, the bi-level mode. And we have some guidelines from UK, published in 2021 from the National Institute for Health and Care Excellence, highlighting that maybe hypercapnia, the level, the degree of hypercapnia is could give the opportunity to have a CPAP treatment or a BiPAP treatment. And for our daily clinical practice, as we can see here, when we are facing hypercapnia, the severe hypercapnia, according to the authors, is greater than 52 millimeters of mercury. Of course, we have also a physiological basis regarding what could offer positive airway pressure treatment in the COPD patients. It will improve oxygenation, it will increase FRC, it will reduce CO2 levels in general. But we don't have many data regarding the use of PaP in COPD patients with obstructive sleep apnea, patients with overlap syndrome. And I think that this is the case because for many, many years, sleep was the forgotten dimension in the management of COPD. And as far as I know, this is the oldest study published in 1997, I think. Dr. Hilas was a student in the medical school at these years, as far as I remember. And as you can see here, it was from Sweden, 88 patients. As you can see here, that there was a clear benefit in those COPD patients with obstructive sleep apnea in which CPAP was applied in terms of hospitalizations. And there was the second study was published in 2010 from Brazil, and as you can see here, it was highlighted the compliance to CPAP treatment. As you can see, there was a great difference between those patients, overlap patients treated with CPAP and those not treated. And it was a clear survival benefit to them. And that was the greatest study until now, I think. It was published in Blue Journal. And as you can see here from Spain, there were more than 650 patients, COPD patients. And those patients who were treated with the CPAP, their survival was comparable to those patients with COPD alone. And that was with a follow-up 9 years approximately. And that was not the case for the patients without treatment with PaP. So we have a clear message here, and that was also replicated in another study from the other part of the Atlantic, from US. And as you can see here, CPAP use was associated with reduced mortality. And some use of CPAP is better than no use at all. As you can see here, there are clear differences in their survival. And this is the larger observational study. It was published 2 years before, I think. And the authors used the data from the United States, from health insurance claims data. And they also have stratified the patients according to compliance to CPAP treatment. And as you can see here, during 2 years of positive airway therapy, there were reductions in patients compliant to CPAP treatment, in emergency rooms visits, in hospitalization and severe exacerbation of COPD. And this is our study, published 1 year before. It was the PhD thesis of one of my colleagues, Dr. Vulgaris. And as you can see here, in a small, of course, number of patients, but we followed them prospectively for 1 year. And according to their baseline characteristics, there were no differences in those patients with good CPAP compliance after 1 year and poor CPAP compliance. And as you can see here, after 1 year, those patients with good CPAP compliance were better in terms of gas exchange, of lung function, as you can see here on a 6-minute walking test, and there are symptoms like dyspnea. And that was also the case for COPD exacerbations. There was a clear reduction in those patients with those overlap patients with good compliance to CPAP use compared to poor compliance with CPAP treatment. And of course, you can see also the control of COPD in terms of symptoms, clear reduction of symptoms in CPAP users compared to non-CPAP users. So these are my conclusions until now, that we have real-world data supporting that positive airway treatment could ameliorate COPD exacerbations, emergency room visits, COPD hospitalization, and healthcare costs, and mortality. Unfortunately, we don't have any data in a milder form of sleep disorder breathing, where oral appliance or positional treatment could have a role. No data at all. So this is my first remark, and the second one is that COPD is a progressive disease, so we need to have a long-term and close follow-up of these patients when we have also obstructive sleep apnea. And the next two slides are from the future, I think, because that will be, I think, the future, because as you can see here, the French database was published 1 year before, I think, and they have followed actually the patients before the initiation of non-invasive ventilation for chronic obstructive pulmonary disease. The French nationwide database is the bigger one worldwide. And as you can see here, they recognized 4 clusters, and the 4 clusters differed in age, sex, and also in their survival. The mortality was higher in cluster 4, in which NIV was started after many severe exacerbations, and the lowest in cluster 1, where the NIV treatment was initiated after the first one exacerbation, COPD exacerbation. And as you can see here, this is the whole population. I think that over there is that 30% of the patients suffer from obstructive sleep apnea, and that was uniform in the 4 clusters. So the last message from me is that before we want to initiate long-term NIV in hypercapnic COPD patients, we should perform a sleep apnea detection with polysomnography, and ideally combined with capnometry. That was my last slide. Thank you for your attention.